This is Audible Bleeding, the vascular surgery podcast. We're here to help you keep your finger on the pulse. Well, welcome to Audible Bleeding. I'm Adam Johnson here with Dr. Sharif Falozi, and today our guest is Dr. Caitlin Hicks. She's an assistant professor of surgery in the Division of Vascular and Endovascular Therapy at Johns Hopkins in Baltimore, Maryland. She received her MD from Case Western in Cleveland, Ohio, and then completed her general surgery residency and vascular surgery fellowship at Johns Hopkins. Although early in her career, she is already an accomplished researcher and has also been appointed a member of the CMS Clinical Expert Subcommittee tasked with refining peripheral vascular disease cost measures and from implementation in the quality payment program. Today, specifically, we'll be discussing her recent work titled Overuse of Early Peripheral Vascular Interventions in Claudication, which has also been recently highlighted in the Wall Street Journal in an article titled Doctors Sound the Alarm Over Leg-Stent Surgery. We'll have the links to both of these in our show notes. So Dr. Hicks, thanks for joining us on the podcast.
Thanks so much for having me. I'm happy to be here.
So we'll get started just to get to know you a little bit more. We always ask our guests, how did you choose vascular surgery and then get involved in health services research in general?
Back in the day, I thought I wanted to do emergency medicine because I liked sort of the quick turnaround and the rapid sort of turnover in patients and feeling like you're making sort of an immediate diagnosis and then moving on and seeing sort of a vast array of different problems. I ultimately ended up wanting to do surgery because of the technical aspects, and I just really loved being in the operating room. But what I found about vascular surgery is that it sort of offered that same thing that I loved about emergency medicine, was that you're treating a vast array of problems within a single specialty. I love being able to do sort of approach different problems using either endovascular or open options. There's medical management is extremely important in these patients, and you actually get a longitudinal relationship with many of them, which is unique to many surgical specialties. So it sort of was a specialty that hit on all parts of medicine that I enjoy. In terms of how I got involved in health services research, when I was in medical school, I did a 5-year program, actually, which required a year of research in the middle. I spent a year at the National Institutes of Health learning research and getting a master's in medical science research, and sort of took off from there. When I got to Johns Hopkins, there's a lot of different people doing a lot of really cool projects. So I started working with a number of them, and it just sort of spiraled from there. Still working in the place where I trained, it's been very easy to get a career off the ground in research. And I really love doing some outcome stuff and stuff that's going to make a difference in the way we practice.
All right, Caitlin, again, thank you for joining us. Maybe for our listeners, especially for some of the people early in trainees, in terms of terminology, if you could just define claudication and describe how it differs from CLTI in terms of the implications for our paperwork today.
Sure. So claudication is essentially pain with walking that's due to arterial stenoses or blockages. It differs from CLTI, which is chronic limb-threatening ischemia, in that claudication doesn't really have a high risk of limb loss. The risk of losing your leg with claudication is about 1% to 2% at 5 years. Patients that have chronic limb-threatening ischemia have an immediate risk of limb loss, and that usually presents as either rest pain, which is pain in their foot, even when they're sleeping, or tissue loss or gangrene, and that's more of a medical urgency or emergency that needs to be dealt with immediately. Claudication is really most frequently dealt with using medical management as a first-line treatment option.
Yeah, so can you go into a little more depth about what the medical management and what the first therapies that vascular surgeons might offer to patients with claudication?
Sure. So the common patient that you see with claudication is generally somebody who smokes. So your very first line of medical management is to offer smoking cessation, whether that's via just counseling or some sort of medication. Really, those patients, if they have claudication and they're still actively smoking, they shouldn't be offered any type of intervention. Because in reality, like I said, the risk of limb loss is extremely low. And the risk of having a complication after an intervention for claudication is actually much higher in people who smoke. Other things that need to be managed medically include putting the patient on an aspirin. Usually a baby aspirin is sufficient, and then a statin as well. Even if they do not have high cholesterol, we believe that statins have a relationship with plaque stabilization and ultimately result in better long-term outcomes. For patients that have claudication that are diabetic, it also involves diabetic blood sugar control. And then the last line of that is actually encouraging exercise therapy. So recently, the CMS actually now starts reimbursing for supervised exercise therapy in patients with claudication. And this really is an important part of their therapy, because if you can encourage these people to walk more, they can develop collateral networks that can actually improve their leg pain, and they can have better quality of life over time.
And so in your practice and, presumably according to the SVS guidelines, where do you see the role for peripheral intervention for claudication?
It's very rare I would offer a patient with claudication any type of intervention at all. Actually, when I see them in clinic, I definitely start with the lifestyle modification factors. So smoking cessation, aspirin, statin, and walking. Even if they come in complaining that it's absolutely just, they can't do anything and they can't walk at all, I still do that. And I have them do that for about 3 months before I see them back. The role of intervention in these patients, as I said, I don't do an intervention in anybody who smokes, and many other vascular surgeons have a similar approach. If the patient has successfully stopped smoking and is doing all the things that you told them and still complains of severe leg pain, that they just that is limiting their lifestyle to the point that they can't do the things that they like, that might be a point where you start talking with the patient about doing an intervention. But it really has to be for a lifestyle limiting problem that's significantly impacting quality of life, not just a little bit of pain with walking that makes them have to pause every now and again.
And then, vascular surgeons are definitely involved with managing these patients, but what other specialties manage these patients as well and might be, offering these services to patients with claudication?
The most common other specialties besides vascular surgery, it would be interventional cardiology, and that's differs depending where you are in the country of how much the cardiologists are involved. And then interventional radiology. So sort of there's 3 big specialties that are managing these patients, and as well as a smattering of people with other types of training, including cardiac surgery, radiology, general surgery, etc., although that's much more rare.
And then when you do offer therapies, in your paper, you discuss the difference between atherectomy, angioplasty, and stenting. Can you just give us a brief overview of the differences between these 3 therapies and their role for when you do choose to intervene?
Sure. So there's a bunch of different technologies that we can use doing endovascular interventions, either for claudication or otherwise. So angioplasty is just a regular balloon. We usually call it plain old balloon angioplasty. We basically put a balloon down into the vessel, blow it up to open up a blockage or a narrowing, and that's it. There's also a drug-coated version of that. Stenting is where you actually open up the lesion and then put a actual stent in there. Some of them are metal. Some of them are metal and covered in Gore-Tex or PTFE. And then there's also a drug-coated version of that. And then the third option is using atherectomy, which is almost like a roto-rooter for the blood vessels. There's a couple different forms of it, but the commonality of that technology is that it shaves away the plaque from the inside of the vessel, trying to open up the true lumen more than using just a stent or a balloon alone. And then after you do that, you can treat either with a balloon that has drug on it or with a stent, depending on how your outcome looks. In terms of outcomes, stents have better outcomes than just regular balloon angioplasty. The drug-coated technologies, I think, do better overall in terms of patency. There is some current controversy about mortality risk associated with the drug-coated technology, so that is a little bit more controversial nowadays. And then atherectomy, there's not great data. There's been no randomized controlled trials looking at atherectomy outcomes head-to-head with either drug-coated technology or stents. So we don't really know where that fits in the whole realm of technology. Most vascular surgeons, I think, believe that it has a role in certain lesions, specifically things where you wouldn't be putting stents like behind a knee or in a joint. Atherectomy can be very helpful because you can still clean out the lesion and then use a balloon to open it up without leaving a piece of product in that space. But as I said, we don't really know what the long-term outcomes are in atherectomy. And actually, the data has sort of borne that out in that the practice patterns across the country are all over the place with that technology.
Okay, well, so thank you for that very quick summary about claudication. So you presented at the Vascular Annual Meeting in June your paper on overuse of early peripheral vascular interventions in claudication. And I think it's in press now, if I'm not mistaken, JVS.
So that paper, basically, we looked at overall practice patterns in the U.S. In Medicare beneficiaries for claudication. So we have access to Medicare data through the Robert Wood Johnson Foundation with me and Martin McCary, who's one of the mentors that I work with. And it actually has Medicare claims data that is linked with physician NPI numbers. So we're able to determine specific physician-based interventions. And we essentially looked at, for each physician, how many patients they saw in a year for claudication diagnoses. And out of those, how many of them went on to undergo an intervention within 6 months, that being either a balloon angioplasty, a stent, or atherectomy.
This was within 6 months of their initial diagnosis.
Correct. So they'd never had a claudication diagnosis before. They saw this physician, got a diagnosis of claudication, and then went on within 6 months of their new claudication diagnosis to have a procedure. We basically looked at the national trends of what percentage of patients were getting interventions by physicians. And in actuality, it's very low. It's around 3.5% to 4.5%. of patients are being offered an intervention for claudication, which is excellent. It means that most physicians within the country are following the guidelines. But there were definitely some outliers that were performing interventions in, more than 15% of patients, which was extremely high compared to the rest of the group.
Yeah, so this is a fascinating study, and I think is a great use of administrative data. Can you just talk about how you really went about going through this administrative data, maybe some limitations, and then how you made sure that the codes you were looking at really maybe reflected what was actually going on in the real world?
Yeah, that's a great question. So the biggest problems with using administrative data is the fact that you rely on coding, so either ICD-9 or ICD-10 coding, which can be very problematic. Specifically for diagnosing claudication, because claudication can be defined as using those codes as sort of very non-specific codes, such as atherosclerosis not otherwise specified, etc. So we basically built a set of codes to identify any type of atherosclerosis or claudication in the lower extremities using previous publications that have done similar research on this. And then we built a second set of codes that identified any type of chronic limb-threatening ischemia, so ulcer, rest pain, gangrene, anything like that. Any patient that had the atherosclerotic codes as well as the critical limb ischemia codes were excluded because we assume those patients had chronic limb-threatening ischemia, and those patients do deserve to have an intervention, so we weren't interested in looking at those. And then we basically fell back into this other group of patients that had just atherosclerosis or claudication codes and used that as our population. We did end up excluding a lot of patients as a result of that, which is sort of one of the major limitations of the study, because we were trying to get a very clean sample of patients that were strictly being treated for claudication. And I think that's sort of the one limitation of administrative claims data. But if you go back and look at other publications on this, we have there's pretty good sensitivity using the codes that we've identified for claudication. So we're fairly satisfied that that was accurate. And again, we're comparing physicians to other physicians using the same set of codes. So we assume that some of any error that was in there would be mitigated due to direct comparisons.
And then just to kind of really clarify the methods a little bit, you took this Medicare coded data and then you merged it with then physician specific data. Is that all in the same data set, or did you use two different data sets and then linked them in some fashion?
No, this was one data set. It's the data set that has physician MPI identifiers linked with the claims that have been submitted. It's actually a data that's not readily available to people, but Martin McCary has a grant through the Robert Wood Johnson Foundation, which has allowed him access to this, and CMS sends him updates on a quarterly basis with this data. He's used the data for a number of other interventions in other fields, including dermatology, gastroenterology, to do some quality improvement projects. And so the data is accessible to us for that. And that's what we're using it for in this setting as well.
But then you also had, physician characteristics such as their location and things like that. I thought something really interesting is that the demographics of the physicians were 96% were male and 93% urban, even split across the specialties. What are your thoughts on that?
Those trends sort of make sense based on what we know. The predominance of males in the specialty is a known issue. It's getting better. I think you're also seeing the one thing that we had to do for these interventions was we had to limit the data to any physician who had performed at least 10 interventions for claudication. So we did lose people who were had a low volume practice, which is probably some very young surgeons. And so by doing that, you may be losing some of your more female spectrum. In terms of the urban-rural differentiation, my guess is it's the same sort of issue. You're seeing higher volume practices in the urban settings and probably some lower volume practices in the rural settings. And so you're not seeing nearly as much of this in those low volume settings.
So could you summarize for us the patient-related factors and the physician-related factors that you found were predictive of overutilization of intervention?
Patient characteristics that were associated with high rates of interventions for claudication included age 65 to 74 years, male sex, hypertension, and smoking. There was also some race-based differences in the early intervention rates that we noted, with white patients having the highest rate of intervention. In terms of physician characteristics were associated with high intervention rates, those also included male sex, more years in practice, being in a rural location, having a low volume claudication practice, and performing a high volume of the procedures in either an ambulatory surgical center or an outpatient-based laboratory.
And you did not find the type of practice, type of training to be predictive of the rates. So it wasn't that, vascular surgeons had lower rates or cardiologists had higher rates or anything like that.
No, and we were a little surprised at that because as a vascular surgeon, we always talk about within the Society for Vascular Surgeons that overtreatment is a specialty-based problem, and that vascular surgeons are trained to not treat patients with claudication, but other specialties don't have similar training. But in fact, in this data set, we did not find that to be the case. All of the intervention rates were relatively similar across specialties.
And am I correct in interpreting when you said the majority of interventions were performed by cardiologists? So does that say that nationwide, the majority of interventions for claudication are being performed by cardiologists overall?
Well, it is a Medicare population based, and I think it's probably because this is specifically endovascular procedures for claudication. I do think that there may be the data shows that there's a higher proportion of cardiologists. A lot of these patients will get sent either to vascular surgeons or cardiologists frequently for their initial treatment. If the cardiologists, what they have in their toolbox is endovascular only, so they may offer them some sort of intervention, and then if they can't do something, then the patient gets sent to a vascular surgeon who has sort of a wider toolbox for lower extremity interventions, which includes both endovascular and open interventions. As I mentioned, the training for vascular surgeons is that we don't frequently offer interventions for claudicants, and whereas I'm not sure that that's the training so much in cardiology, so we did expect there to be a difference in the intervention rates across specialties. But we were a little surprised to find that was not the case.
But just to clarify, the population of physicians are those that have diagnosed patients with claudication, not necessarily those that intervened. Is that correct?
That's correct. And so that may also play into this a little bit because patients going into a cardiologist office to get their heart checked are perhaps getting some sort of lower extremity exam, which may lead for them to have a new diagnosis of claudication within that office, as opposed to a vascular surgeon who's usually being sent a patient that has some sort of perceived vascular problem already.
And then in your paper, you mentioned, okay, what's the next step for how to use this data? You mentioned something about providing benchmark performance and data back to surgeons about their rates of intervention for claudication. What in the real world, what do you think that would look like?
Yeah, that's our ultimate goal, and we've done it for other specialties, actually. So the goal would be to send some confidential benchmarked reports, sort of like what hospitals get for the NSQIP data, but on a physician-specific level, to physicians to say, hey, you're performing outside of the range of your peers, and perhaps providing some educational material showing why interventions for claudication should not be your first-line treatment. And then just by bringing that attention towards the fact that some certain physicians are practicing outside the realm of normal, perhaps we can improve their adherence to the societal guidelines. We've done this with Mohs surgeons, which is a form of dermatology, looking at number of slices taken for biopsies. We've done this now for the American Venous and Lymphatic Society, looking at a number of endovenous thermal ablations for patients with varicose veins. And it's proven to be extremely effective just by bringing physicians' attention to the fact that they are performing differently than their peers. We see a lot of autocorrection. And the idea is that it's meant to be a non-punitive feedback mechanism. So it's not meant to be something that is punished or that affects reimbursement at all. It's really just meant to be an informative letter to say, you are different than everybody else. Perhaps you should look at your practice patterns.
So you, as we mentioned before, you presented this at the Vascular Annual Meeting in June, and the articles in press and the JVS, but really, perhaps more impressively, you made it to the pages of the Wall Street Journal in September. And so how have you seen the response to the article? Have you noticed an uptick in attention?
Yeah, there's been a lot of attention. I think a lot of people read the Wall Street Journal for some of their lay medical information. So it's been sort of exciting in that front. We've got a lot of attention from people that we haven't heard from before. That actually came about because we sent a letter to the Society for Vascular Surgeons highlighting our findings, both for claudication and then also for us side finding about atherectomy utilization, and basically just saying like, hey, we have this data, we found a bit of a problem with practice patterns. Do you want to partner with us to do some sort of peer-based benchmarking intervention to make things better? And the Society for Vascular Surgery has been very receptive. We've had multiple phone calls with the president of Dr. Kim Hodgins, and I think they're eager to sort of nip this in the bud and proceed with some sort of peer-based performance reviews.
So some of the counter, arguments to some of this is kind of the concept of big brother and being watched and kind of being told what to do and infringing a little on physician autonomy. Have you seen any of that? Have you gotten any feedback like that? And what's kind of your response to some of those criticisms?
We get a little bit of feedback like that. I think in general, the feedback is mostly positive because most people in the specialty want to do what's right. And so when we're seeing data like this, everybody knows that it's a problem within certain physicians. And so we appreciate that there's now perhaps a mechanism in which that can be managed in a way that doesn't punish people. But we do get occasionally some pushback for the reasons that you mentioned. And really my response to that is that we are trying to get ahead of having a big brother situation. I mean, this data is available. We got the data from CMS, so they have access to it. If they were to do this type of project and not us, you could perhaps be seeing some reimbursement punishments, some cuts, or some perhaps pre-authorization requirements in order to do interventions on patients with claudication that we really want to avoid. So I think if we can self-police ourselves, that's a better option than leaving this to let somebody else do it for us.
I think that's a great point in really taking ownership of our specialty as a whole, instead of letting someone else do it for us. Another question I had is, with this study and kind of some of the ethical considerations around it, we have a lot of ethical guidelines for studies about patients and including them in studies. But what are your ethical obligations for providers? Because this is kind of a research study where the subject is also the providers and the physicians who provide the care. These providers didn't really consent to be in the study. What are the ethical obligations around that in health services research?
Yeah, that's a good question. And I think, with the increasing availability of data from these different data sets, we're going to run into this more and more of how do people consent to be involved in projects that are sort of, if you will, publicly available. Our data does have physician identifiers. We have managed this we went through the institutional review board, and because the data is technically publicly available via CMS, they didn't feel like we had to have direct consent, which is obviously be impossible in a project like this. But we have tried to mitigate any ethical problems by keeping it strictly confidential. So we haven't been publishing physician names that are outliers. The peer-based benchmark reports that I've mentioned that we are proposing to send out wouldn't be the entire specialty saying, here's the outliers and naming them. It was meant to be private to the directed involved physician. And if that physician were to contact us and say, well, I don't want to be involved with this, then we would absolutely take them out of the project. But I do think there becomes a sort of a tightrope walking there. You want to be helpful, but you don't want to violate people's privacy. And I'm not exactly sure that health services in general has figured out the best way to approach that.
So that sort of leads to our next question. What do you think the best way is for health services researchers to become involved in advocacy and policy development?
Well, I think sort of the first step is finding something that you're passionate about, a topic, and just knowing everything you can about it. And that's sort of what I've done with this peripheral vascular intervention concept, because you really need to be the expert in something in order to be able to talk about policy at all. So sort of starting from that standpoint, the next step becomes a little bit more complicated, and a lot of it's about getting to know people that can help you get access to the people that you need to speak to in order to do some health advocacy. But there are PACs in every society that you could become involved with. Those have frequent interactions on the Hill, in Capitol Hill. And if there's truly something that you're passionate about, you can work with your local politicians to try to get that brought forward as a sort of important component in the area where you're working. But it does sort of making the leap from health services research to policy and advocacy. I'm new at this, and I've just started to get involved with this, and largely by the help of Dr. McCary, who's got a lot of connections that I otherwise wouldn't have. So a little bit of it is about knowing what you're doing, and a little bit is about knowing people who can help you get in front of the people you need to get in front of to make a difference.
And I think, there's also been some work in the lay press about some of the comments of the former dean at University of Pennsylvania about whether physicians should be scientists or should be, involved in public policy and these other realms.
I think his specific criticism was teaching social justice in medical school.
In this, social justice and kind of taking our research kind of into the more public policy realm, are there conflicts between the hats of being a clinician, a researcher, and then a public policy advocate?
I think it becomes one of those things that everybody has what they're good at, and sort of people want other people to stay in their lane of what they know. But in reality, physicians need to be involved in public policy because the public policies involving healthcare are reliant on physician input. You can't just have a bunch of politicians making decisions on appropriateness in surgery or medicine in general. You really do need to have some input from physicians who have a vested interest in how this is managed. So I think there is a room for everybody, for physicians to do health services research and public policy in addition to medicine. But I think that it has to do with the understanding that we're working together as a team and not just sort of bulldozing our way in and trying to make policy where there wasn't one before.
I think that's a great way to summarize everything. And we've really enjoyed having you on the podcast. Any final words for our listeners or anything to leave us with?
No, I think just anybody who's interested in doing these types of health services research, appropriateness is becoming a really hot topic right now. And it's sort of applicable in any type of specialty, so vascular surgery and otherwise. And I think it's important. We're going to see the world moving in a direction where we're not only providing good care for patients in terms of quality as in good outcomes, but actually whether we even provide care at all in terms of interventions is a really important part of the puzzle. And until now, we really haven't had a way to address that with all the various quality measures that are available. But I think we're going to see it coming down the pipeline. And if we can get ahead of it and sort of be our own advocates to define what that looks like for each individual specialty, then I think that we'll be ahead of the game.
Yeah, I do like the idea of us as a specialty sort of self-policing before being told by the government that we're too expensive for our care.
Absolutely.
All right. Well, thank you very much.
Thanks for having me.
We are Audible Bleed, the vascular surgery podcast. Our team is committed to providing free, high-quality, unbiased content to our listeners. We currently do not take any funding from industry sponsors or advertising, and we hope to keep it that way. So if you want to help us keep bringing you great content, go to audiblebleeding.com/support and find out how. We'll put a link in our show notes.